Welcome. In this session, we'll be discussing about pathologic myopia and angioid streaks, two entities in which breaks occurring in Bruch's membrane may lead to macular neovascularization and its sequelae. Breaks in Bruch's membrane can occur with blunt ocular trauma, pathologic myopia, angioid streaks, and inflammatory diseases. We'll be discussing about traumatic choroidal rupture in the session on posterior segment ocular trauma. In non-pathologic myopia, increase in axial length of the eye occurs due mainly to expansion of the eye at the equatorial region, whereas in pathologic myopia, the increase in axial length occurs mainly due to posterior staphyloma formation at the posterior pole of the globe, and this posterior staphyloma is the hallmark of pathologic myopia. Myopic macular degeneration occurs in pathologic myopia, and incidence of myopic maculopathy in pathologic myopia increases with age. Myopic maculopathy has the potential to cause irreversible vision loss, often bilaterally, in the most productive years of life. Both myopia and high myopia have the highest prevalence among Asians, particularly East Asians, and the prevalence of myopic maculopathy has been found to range between 1% to 3% in various studies. Myopic maculopathy has been found to be the leading cause of blindness in certain countries such as Japan. Known risk factors for development of myopia include decreased outdoor activities and concentrated near work, and prevention of myopia includes addressing these factors and application of low concentration atropine eye drops. Genome-wide association studies has linked two loci with myopia, and pathogenic mutations in 6 genes have been associated with pathologic myopia. Excessive axial elongation and posterior staphyloma formation are important features of pathologic myopia which lead to the development of myopic maculopathy, and aging is also said to contribute to the development of myopic maculopathy in pathologic myopia. Incidence of Lacquer cracks and macular neovascularization in pathologic myopia, which we will be discussing further, have not been associated with axial length, and the incidence of myopic macular neovascularization has been seen to peak in the 4th decade of life. Several features may be detected on examination of an eye with pathologic myopia, and we will be discussing these features individually with their clinical and imaging characteristics. As we have mentioned, posterior staphyloma is the hallmark of pathologic myopia, and this is very important to remember. Posterior staphyloma results from derangement of growth and organization of collagen fibers of the sclera, leading to thinning of the sclera at and posterior to the equator of the eye, with scleral thinning increasing in severity at the posterior pole. Thinning of the sclera results in posterior staphyloma formation, which is a localized ectasia of the posterior sclera, as seen here in this USG-B scan and in this MRI image, and at the border of the staphyloma between the two curvatures. RPE changes and macular neovascularization, which we are going to discuss, are more likely to occur, and if this border passes through the superior border of the optic disc, a tilted optic disc results, and it has been seen that irregularity of inner scleral curvature is associated with a higher risk of myopic maculopathy. Clinically, the posterior staphyloma appears as an outward protrusion of all layers of the posterior globe. Posterior staphyloma formation is rare in children with high myopia, and prevalence of posterior staphyloma increases with age, and it has been seen that in half of the eyes with high myopia, posterior staphyloma does not occur. Clinically, posterior staphyloma has been classified according to its size and extent. The wide macular type is the most frequent, followed by the narrow macular type. Other types of posterior staphyloma are peripapillary around the optic disc, nasal, inferior, and other variants. Posterior staphyloma in OCT typically shows a curvature of the posterior sclera, and this curvature of posterior sclera can be of 4 types. In the first one, the sclera appears to slope towards the optic disc, with the optic disc being the posterior-most location of the globe, and the surface of the sclera in the macular region is straight. The second type is a symmetric curvature of the posterior sclera around the fovea, with the fovea being the posterior-most location of the globe. in asymmetric curvature of the posterior sclera around the fovea, and extrafoveal location is the posterior-most location of the globe, and the fovea lies in one of the slopes of the posteriorly curved sclera. And the fourth type is an irregular curvature lacking a smooth surface, which, as we have mentioned, is associated with a higher risk of myopic maculopathy. Choroidal atrophy occurs in high myopia, which is a thinning of the choroid with loss of choriocapillaries. In the absence of other features of myopic maculopathy such as Lacquer cracks, macular neovascularization, and Tractional maculopathy, thinning of subfoveal choroid itself is said to be the major cause of diminution of vision in highly myopic eyes. Thinning of the choroid is followed by pigment granularity in the overlying RPE and increased visibility of underlying larger choroidal blood vessels. And the appearance of this alternating pattern of larger choroidal blood vessels and pigment is called tessellation, as seen here in this clinical photograph, and is almost a universal feature in eyes with high myopia. With continued thinning, choroid and retinal pigment epithelium disappear, exposing the underlying sclera as wide ovoid areas, as seen here in this clinical photograph, and these are called patchy choroidal atrophy of myopia. Patchy choroidal atrophy in subfoveal area results in poor visual acuity. So clinically there are two types of myopic choroidal atrophy, diffuse and patchy. In diffuse choroidal atrophy, there is an ill-defined yellowish-white area of choroidal thinning, as seen here in this photograph, where only sporadic large choroidal vessels are visible, and patchy choroidal atrophy, which are well-defined greyish-white areas where choroid, RPE, and outer retina are absent. Patchy choroidal atrophy develop within an area of diffuse choroidal atrophy, as seen here in this clinical photograph, with this being the area of diffuse choroidal atrophy and these being areas of patchy choroidal atrophy within the area of diffuse choroidal atrophy. On optical coherence tomography, diffuse choroidal atrophy appears as marked thinning of choroid, as seen here in this OCT image, with remaining larger choroidal vessels sometimes indenting the surface of the RPE. Patchy choroidal atrophy, as seen here in this OCT image, corresponding to the patchy choroidal atrophy seen in this color photograph, appears as an area where choroid, retinal pigment epithelium, and outer retina are absent, and the inner retina sits directly over the sclera. And the increased transmission hyperreflectivity underlying the patchy choroidal atrophy is because of absence of the overlying retinal pigment epithelium. Patchy choroidal atrophy shows choroidal vascular filling defect on fluorescent angiography and indocyanine green angiography. So fluorescent angiography and indocyanine green angiography of this fundus with a patchy choroidal atrophy show corresponding zones of choroidal vascular filling defects, and fundus autofluorescence shows a zone of hypoautofluorescence corresponding to a zone of choroidal atrophy because of a reduction in the number of retinal pigment epithelial cells and their lipofuscin content in the zone of choroidal atrophy. Intrachoroidal cavitation is detected on OCT in 5 to 10% of highly myopic eyes, particularly in the peripapillary region, and they are associated with a posterior bowing of the sclera around the optic nerve, and clinically it correlates with an orange area in the fundus, usually nasal to the optic nerve head. These two OCT-B scans correspond to the A and the B lines respectively in this clinical photograph, and here we find a cavitation within the choroid with a zone of thinning of the overlying retina, which is also known as pseudofovea. Cracks occurring in Bruch's membrane in pathologic myopia are known as Lacquer cracks, and these cracks may cause rupture of underlying choriocapillaries resulting in subretinal hemorrhage. And subretinal hemorrhage occurring from Lacquer cracks in the absence of macular neovascularization may be difficult to distinguish from subretinal hemorrhage from macular neovascularization, which also ingress into the subretinal space through the Lacquer crack. So in this fundus image, these areas are that of patchy choroidal atrophy, and this is a Lacquer crack. Lacquer cracks appear as linear yellowish lines as seen in this photograph, and they tend to increase in number and width with time. And as we have mentioned, formation of a new Lacquer crack may be associated with subretinal bleeding from choriocapillaries damage even in the absence of a macular neovascularization. Following reabsorption of this blood, Lacquer cracks appear as yellowish linear lesions. Lacquer cracks by themselves may cause visual distortion when they pass through foveal center, and Lacquer cracks allows ingress of macular neovascularization, which is very important to remember. In this pair of photographs, we find a Lacquer crack increasing in length and width over time. And in this pair of photographs, we find new Lacquer cracks appearing over time as compared to the previous photograph. The Lacquer cracks may appear on OCT as linear hyperreflectivities underlying a crack in the Bruch's membrane, but are usually difficult to detect with OCT. Lacquer cracks are better detected with fluorescent angiography, where they appear as linear hyperfluorescence because of relative deficiency of overlying retinal pigment epithelium, on ICGA as linear zones of relative hypocyanescence because of relative deficiency of choroidal vasculature underlying the Lacquer crack, and on fundus autofluorescence as linear zones of hypoautofluorescence because of deficiency of overlying RPE and its liposuction. Octa show flow deficits corresponding to Lacquer cracks, and in the absence of macular neovascularization, vascular network is not detected in the zone of the Lacquer crack. Dome-shaped macula is an imaging feature on OCT in highly myopic eyes, in which we find convex protrusion of the macula located within the posterior staphyloma, and it is found in 20% of highly myopic eyes. It occurs due to localized relative thickening of the sclera within the macular region in highly myopic eyes, and this is in contradistinction to the generalized thinning of sclera posterior to the equator in highly myopic eyes. In young eyes with pathologic myopia, the retinal thickness in the macular region is normal, but with age and progression of the disease, thickness of outer retina decreases. But in areas outside the macula, the thickness of the retina is reduced in pathologic myopia. In the retinal periphery, lattice degeneration is found more commonly in myopic eyes as compared to emmetropic eyes, and we'll be discussing about lattice degeneration in the session on peripheral retinal degeneration and retinal detachment. Before continuing with myopic macular degeneration, we'll discuss the optic nerve changes in high myopia. In high myopia, there is stretching, enlargement and tilting of the Bruch's membrane opening. In this diagram, the green line represents the retina and the optic nerve fibers, the brown line represents the Bruch's membrane anterior to the choroid, and the black line represents the sclera. And the Bruch's membrane opening, which we have also discussed in the section on glaucoma, is the zone between the two terminations of the Bruch's membrane on either side of the optic nerve head. In high myopia, Bruch's membrane opening at optic nerve head shifts so that the nasal portion of the optic nerve head is undermined by the nasal margin of the Bruch's membrane opening. As a result, the nasal nerve fibers of the optic nerve have two coats around the nasal margin of the Bruch's membrane opening, and this is called supertraction. On the other hand, temporal margin of the Bruch's membrane opening does not reach the temporal margin of the optic nerve head, exposing the white sclera, which is called the myopic crescent. Tilting of optic nerve head is also found in highly myopic eyes, and it is said to occur when the superior margin of the posterior staphyloma passes adjacent to the superior margin of the optic nerve head. And in these two clinical photographs, we find mild tilting and severe tilting of the optic nerve head in highly myopic eyes. Defects in lamina cribrosa within the optic nerve head can also be found in highly myopic eyes on OCT, and these defects in lamina cribrosa in highly myopic eyes are usually not associated with splinter hemorrhages. Myopic eyes have a higher risk of glaucoma, but glaucoma diagnosis in myopic eyes is difficult. This is because OCT RNFL analysis is confounded by temporal shifting of the superior and inferior RNFL bundles of the optic nerve head. Automated perimetry results are confounded by abnormal shape of the fundus and myopic retinal degeneration, and most commonly, diagnosis of glaucoma in myopic eyes is made by detecting progression of glaucoma over time. Myopic macular neovascularization is an important cause of visual impairment in myopic maculopathy, and this is important to remember. Myopic macular neovascularization is typically type 2 or subretinal in nature and develops in 10% of all highly myopic eyes, and the fellow eye of an eye with myopic MNV has a 30% risk of developing myopic MNV. Myopic MNV may occur in an area of lacquer crack, as we have discussed, or as an extension from a zone of pre-existent choroidal atrophy. Myopic MNV typically cause metamorphopsia and loss of visual acuity, and the MNV may be detected clinically as a grayish membrane as seen in this color photograph. It may be difficult to detect in highly myopic eyes as represented in this color photograph, and associated subretinal bleeding is infrequent in myopic MNV as compared to MNV of age-related macular degeneration. Myopic MNV regresses into a scar with overlying proliferation of retinal pigment epithelium, resulting in a dark pigmented spot called fuchs spot as seen here in this color photograph. Subsequently, well-defined choroidal atrophy develops surrounding the scarred MNV as seen here in this color photograph and continues to enlarge for years. Natural history of myopic MNV without treatment is poor. At the onset of MNV, 70% of patients have a visual acuity of better than 20/200, but after 10 years, only 4% of patients have a visual acuity of better than 20/200. Myopic MNV on OCT typically appears as an elevated subretinal lesion as seen here in this OCT image, and 50% of myopic MNV are not associated with either intraretinal or subretinal fluid, and so determining activity of myopic MNV is difficult on OCT, and so is determining response of myopic MNV to treatment. On fluorescein angiography, myopic MNV has a classic appearance as seen here in this fluorescein angiogram. ICGA usually does not show hypercyanescence because of low activity of myopic MNV. Octa shows a vascular network as seen here in this Octa image, and in the absence of exudative features of many myopic MNVs, Octa becomes an important modality to monitor response of myopic MNVs to treatment, and this can be done by evaluating decrease in flow area and attenuation of feeder vessels of the myopic MNV on Octa. Tractional myopic maculopathy, as seen here in this OCT image, is found in 9% of highly myopic eyes with posterior staphyloma, and when eyes with posterior staphyloma develop tractional myopic maculopathy, the tractional myopic maculopathy is localized within the posterior staphyloma. But when tractional myopic maculopathy occurs in eyes without posterior staphyloma, the tractional myopic maculopathy is found to be more extensive. Tractional myopic maculopathy can result from attached vitreous, scheme of vitreous attached to the retina following a posterior vitreous detachment, epiretinal membrane, and traction from blood vessels. Imaging features of tractional myopic maculopathy on OCT include retinoschisis, which usually occurs in the Henle's layer or outer plexiform layer, but can occur in other layers of the retina as well. In this OCT image, we see retinoschisis in the outer plexiform layer, in the inner nuclear layer, and in the nerve fiber layer. Tractional myopic maculopathy can also result in foveal detachment, lamellar macular holes, and full thickness macular holes. Full thickness macular holes with retinal detachment can occur in 50% of patients with myopic traction maculopathy, and full thickness macular holes in high myopia can lead to more extensive and often complete retinal detachment as compared to full thickness macular holes in emmetropic eyes. Meta-PM is a clinical classification of myopic maculopathy which categorizes the progression of myopic maculopathy as no maculopathy, tessellation of fundus as seen here in this photograph, diffuse choroidal atrophy as seen here in this photograph, patchy choroidal atrophy as seen here in this photograph, and macular atrophy as seen here in this photograph. And it categorizes the occurrence of lacquer cracks, myopic macular neovascularisation, and fuchs spots as plus disease, which occur independent of the progression categories. And eyes having category 2, that is diffuse choroidal atrophy or Wart's disease, or those with plus disease, are considered to have pathologic myopia. Being a clinical classification system, Meta-PM does not include features of pathologic myopia which are detected primarily on imaging, such as dome-shaped macula, intrachoroidal cavitation, and traction maculopathy. The first-line therapy for myopic macular neovascularisation is anti-VEGF injection, and this has been established primarily by 3 studies. The REPAIR study was a phase 2 study evaluating efficacy of intravitreal ranibizumab for myopic MNV in a 1+ PRN regimen over 12 months. 1 plus PRN regimen involves giving one injection and subsequent injections being given only as required. 86% of patients with myopic MNV showed improvement in BCVA with intravitreal ranibizumab, and 36.9% of patients showed BCVA gain of 15 letters or more. The mean number of injections required in 12 months was 3 in repair study. The Radiant study was a randomized controlled trial comparing ranibizumab versus photodynamic therapy for myopic MNV over 12 months, and it compared 3 groups, one receiving 2 injections of ranibizumab at 1 month interval followed by PRN dosing, one receiving ranibizumab 1 injection followed by PRN dosing, and the third group receiving verteporfin PDT and PRN dosing of either ranibizumab or verteporfin PDT. And the Radiant study found that ranibizumab was superior to PDT as regards mean BCVA change over 12 months. The Mirror study compared intravitreal aflibercept versus sham for myopic MNV. The aflibercept group received 1 injection of aflibercept followed by PRN dosing, and the sham group received sham injections till week 24 and then after assessment received intravitreal aflibercept. At week 24, there was an improvement in BCVA in the aflibercept group, whereas there was a decrease in BCVA in the sham group, and at week 48 the mean change in BCVA was maintained in the aflibercept group and improved over the results in week 24 in the sham group, who later received aflibercept as required. It is important to note here that number of injections required or given in these trials on myopic MNV were much less than the number of injections required in trials on neovascular AMD, and although retreatment decisions in MNV are often based on OCT findings, as we have mentioned, OCT findings of activity of myopic MNV can be subtle or absent, and this is very important to remember. So retreatment decisions in myopic MNV should include recurrence of visual symptoms and decline in visual acuity. Myopic traction maculopathy required vitrectomy with non-foveal ILM peeling, and myopic macular hole require inverted ILM flap, which we will be discussing in the session on vitreous surgery. And it has been found that myopic macular holes have a poorer postoperative outcome as compared to macular holes in emmetropic eyes. Angioid streaks are irregular linear dehiscences of the Bruch's membrane radiating from and concentrically surrounding the optic nerve head, as seen here in these 2 clinical photographs. Calcification of Bruch's membrane is the primary pathology of angioid streaks, and this makes the Bruch's membrane brittle, and this is very important to remember. Calcification of Bruch's membrane starts in the posterior pole and extends centrifugally. Early stage angioid streaks are partial breaks in the thickened and calcified Bruch's membrane with thinning of overlying RPE, but overlying retina and underlying choriocapillaries are not affected in early stage angioid streaks. Late stage angioid streaks are full thickness dehiscence in Bruch's membrane with atrophy of adjacent RPE as well as the retina and the choriocapillaries. Fibrovascular proliferation occurs through late stage angioid streaks or full thickness defects in Bruch's membrane, similar to fibrovascular proliferation occurring through lacquer cracks in myopic maculopathy, ultimately resulting in scar formation. Systemic associations of angioid streaks are important to remember, and angioid streaks have been most commonly associated with pseudoxanthoma elasticum, Paget's disease of bone, Marfan syndrome, Ehlers-Danlos syndrome, and sickle cell disease. Pseudoxanthoma elasticum is an autosomal recessive disorder characterized by progressive calcification and fragmentation of elastic fibers, particularly in the skin, eye, and the cardiovascular system. The average age of onset of clinical features of pseudoxanthoma elasticum is 13 years, and the first clinical manifestation of pseudoxanthoma elasticum is usually cutaneous, with a plucked chicken appearance of the skin in the lateral aspect of the neck, as seen here in these 2 clinical photographs. Premature calcific atherosclerosis resulting in cerebrovascular and gastrointestinal hemorrhages is also a clinical feature of pseudoxanthoma elasticum. Pseudoxanthoma elasticum is the most common cause of angioid streaks, and almost all pseudoxanthoma elasticum patients ultimately develop angioid streaks, and most patients with pseudoxanthoma elasticum ultimately develop macular neovascularization and extensive RPE atrophy. In addition to angioid streaks, other ocular changes can occur in eyes of patients with pseudoxanthoma elasticum, but these clinical features do not occur in other disease entities causing angioid streaks. Among these we have PUD orange, which appear as small orange-red nodules in the mid-periphery of the retina, mostly temporally, and the zone of PUD orange indicates the transition zone between calcified area of Bruch's membrane occurring in the central portion of the posterior pole and the more peripheral uncalcified area of Bruch's membrane. And as we have mentioned, angioid streaks are limited within the zone of continuous calcification of the Bruch's membrane, and the zone of PUD orange is an area of discontinuous calcification of the Bruch's membrane. Pattern dystrophy-like lesions are also found in eyes of patients with pseudoxanthoma elasticum as seen in these clinical photographs and their corresponding fundus autofluorescence images, and they appear as yellowish deposits and hyperpigmentation in the posterior pole. Pattern dystrophy-like lesions in pseudoxanthoma elasticum occur after years of subretinal fluid accumulation and predates the occurrence of macular neovascularization or macular atrophy. Comet tail is another finding in eyes of patients with pseudoxanthoma elasticum, and these are whitish lesions mostly in the inferior periphery with their tails directed towards the optic nerve head. Optic nerve drusen, as seen here in this clinical photograph, can also occur in eyes of patients with pseudoxanthoma elasticum. Entities other than pseudoxanthoma elasticum which are associated with angioid streaks include Paget disease of bone, which tend to occur after 50 years of age and is characterized by excessive and abnormal remodeling of bone. And Paget's disease of bone manifests with bone pain and deformities in the skull, spine, and pelvis. And only 10% of patients with Paget disease of bone develop angioid streaks. Angioid streaks can also occur in eyes of patients with Ehlers-Danlos syndrome, Marfan syndrome, acromegaly, blood dyscrasias such as sickle cell anemia, thalassemia, and spherocytosis, and mineral abnormalities. And angioid streaks have also been found in eyes of individuals without any associated systemic disorder. As in eyes with lacquer cracks in myopic maculopathy, patients with angioid streaks may also present with sudden onset of metamorphopsia and blurred vision, either due to angioid streaks passing through the foveal center with or without a subretinal hemorrhage, and when this occurs in the absence of a macular neovascularization, visual decline may spontaneously resolve, albeit partially, and sudden onset of metamorphopsia and blurred vision may also occur due to development of macular neovascularization through an angioid streak with subsequent exudation and hemorrhage in the foveal area. Also, most pseudoxanthoma elasticum patients develop poor vision after 50 years of age due to development of extensive chorioretinal atrophy. Clinically, angioid streaks appear as irregular lines of varying width, usually originating from the optic nerve head, either radiating outwards or remaining concentric around the optic nerve head. So these are the angioid streaks radiating peripherally from the optic nerve head, and these are the angioid streaks remaining concentric with the optic nerve head. Angioid streaks appear red in color in light-skinned individuals and brown in color in dark-skinned individuals. And like lacquer cracks, with time angioid streaks increase in number and width, and new angioid streaks develop, and existing angioid streaks never regress. Subretinal hemorrhages in eyes with angioid streaks may be provoked by mild head or eye trauma, and minor head or eye trauma may lead to rapid extension of angioid streaks and widespread subretinal hemorrhages, as seen here in this clinical photograph. Macular neovascularization develops in 80% of patients with angioid streaks, as seen here in this clinical photograph, and macular neovascularization in patients with angioid streaks is often bilateral but temporally asymmetric. Macular neovascularization in angioid streaks is most common in eyes of patients with pseudoxanthoma elasticum, and like myopic MNV, MNV occurring in eyes with angioid streaks is typically type 2 or subretinal in nature. But unlike myopic MNV, MNV occurring in eyes with angioid streaks are frequently associated with exudation and hemorrhage. Another clinical feature which can occur in eyes with angioid streaks, and particularly in eyes of patients with pseudoxanthoma elasticum, is choroidal atrophy, as seen here in these two photographs. And choroidal atrophy in these eyes typically occur either adjacent to angioid streaks or following regression of macular neovascularization. On fluorescent angiography, angioid streaks show irregular transmission hyperfluorescence in early phase and staining in late phases. Fluorescent angiography is also useful in detecting macular neovascularization in angioid streaks, as seen here in this fluorescent angiogram, and fluorescent angiography can also demonstrate comet tail lesions which appear hyperfluorescent, as seen here in this fluorescent angiogram, pigmentary changes and scarring. On indocyanin green angiography, angioid streaks appear as speckle pattern of hypercyanescence radiating from the optic disc, as can be seen here in this ICG angiogram. And in late phases of ICGA, areas with calcified Brooks membrane, which as we have mentioned occurred centrally in the posterior pole, show relative hypocyanescence as compared to the peripheral areas with uncalcified Brooks membrane. And as we have mentioned earlier, angioid streaks do not extend peripheral to this junction, and it is at this junction where podi orange is located. Comet tail lesions appear hypocyanescent on ICGA. On fundus autofluorescence imaging, angioid streaks show hypoautofluorescence with adjacent focal areas of hyperautofluorescence, as seen in this wide field FAF image. And this is another FAF image showing hypoautofluorescence along the angioid streaks. In pseudoxanthoma elasticum, comet tails and orange drusen may appear hyperautofluorescence, and pattern dystrophy-like changes which we have discussed may also be detected. But podi orange is typically not seen on fundus autofluorescence. On OCT, eyes with angioid streaks show hyperreflectivity of the Brooks membrane corresponding to calcified areas of the Brooks membrane. In this OCT-B scan, we find increased hyperreflectivity of the Brooks membrane in the posterior pole as compared to more peripheral regions of the Brooks membrane, and this increased hyperreflectivity in the posterior pole corresponds to calcification in the Brooks membrane occurring earlier in the posterior pole. These are OCT images in black on white format, in which darker areas are hyperreflective areas and lighter shaded areas are hyporeflective zones. Brooks membrane breaks can also be detected on OCT, as seen here in these three OCT images, and Brooks membrane undulations are commonly found in the peripapillary area and are said to lead to Brooks membrane breaks and macular neovascularization. OCT can also detect macular neovascularization, as seen here in this OCT image, and subsequent subretinal fibrosis, and in-face OCT can also detect Brooks membrane breaks and macular neovascularization. As we have mentioned earlier, subretinal fluid, as seen here in this OCT image, can be present for years before development of MNV in eyes with angioid streaks, and in these eyes, subretinal fluid may persist even after resolution of the MNV. And so, in eyes with angioid streaks, presence of residual subretinal fluid should not be considered as a sign of activity of MNV. And long-standing subretinal fluid accumulation can lead to deposition of hyperautofluorescent vitelliform material, which appear as pattern dystrophy-like lesions, as seen here in this colored photograph and fundus autofluorescence image. In eyes with angioid streaks, octa is better than fluorescent angiography or indocyanin green angiography in detecting macular neovascularization, because on fluorescent angiography and indocyanin green angiography, both angioid streaks and MNV show hyperfluorescence and hypercyanescence, and it becomes difficult to differentiate macular neovascularization from background angioid streaks. Protection of eye from even a mild trauma is a very important component of treatment in eyes with angioid streaks, and this is very important to remember. And medical consultation to detect and manage any associated systemic disease is also important. Anti-VEGF therapy is the treatment of choice for MNV associated with angioid streaks. An anti-VEGF therapy in this scenario results in superior outcome as compared to laser photocoagulation, photodynamic therapy, or surgery, with most patients demonstrating gain in visual acuity, which does not occur with these treatment modalities. Recurrence rate of MNV following treatment in angioid streaks is significant, occurring either at the same location or at a new location, and vision decline following therapy of MNV in eyes with angioid streaks is due to development of macular atrophy. Combining anti-VEGF therapy with PDT seems to have similar visual outcome as compared to anti-VEGF therapy alone, but with a lower recurrence rate of MNV. Visual prognosis in eyes with angioid streaks depends on location of macular neovascularization or angioid streaks, and subfoveal location of either portends a poor prognosis as compared to juxtafoveal or extrafoveal location. Macular neovascularization can also occur in inflammatory chorioretinal diseases such as posterior uveitis and panuveitis entities, multifocal choroiditis, punctate inner chorioretinopathy, presumed ocular histoplasmosis, and serpiginous choroidopathy. Macular neovascularization in inflammatory chorioretinal diseases may occur either during active phase of inflammation or through scar of a healed chorioretinitis. It is said that during active phase of the inflammation itself promotes angiogenesis, which alters the Bruch's membrane by tissue remodeling, and in a healed chorioretinitis scar, breaks may be present in the Bruch's membrane, which may allow ingress of blood vessels. Importantly, MNV in inflammatory diseases, particularly during the active phase, may respond to anti-inflammatory therapy, which should be tried when MNV occurs in active phase of posterior uveitis or panuveitis, and this is important to remember. To recap the salient points, pathologic myopia and angioid streaks are disease entities in which breaks may occur in the Bruch's membrane, which may lead to ingress of macular neovascularization in the subretinal space with its sequelae. Even without development of macular neovascularization, breaks in Bruch's membrane occurring in the foveal region may lead to decrease in visual acuity with or without subretinal hemorrhage. Pathologic myopia is characterized by posterior staphyloma formation, which is a localized ectasia of the wall of the posterior portion of the globe. Myopic choroidal atrophy occurring in pathologic myopia can be either diffuse or patchy, with patchy choroidal atrophy representing well-defined areas where choroid retinal pigment epithelium and outer retina are absent and inner retina rests directly on the sclera. Lacquer cracks are breaks in Bruch's membrane occurring in eyes with pathologic myopia. Their number, length, and width increase over time. Dome-shaped maculopathy, intrachoroidal cavitation, and tractional maculopathy are other features which may occur in pathologic myopia. Macular neovascularization in pathologic myopia can occur through a Lacquer crack or as an extension of an area of patchy choroidal atrophy. With or without treatment, myopic MNV may regress into a pigmented spot called Fuchs spot with development of surrounding choroidal atrophy. Myopic eyes are at a higher risk of glaucoma, but optic nerve changes in pathologic myopia may make it difficult to diagnose glaucoma either with perimetry or RNFL analysis. Causes of decline in visual acuity in pathologic myopia include diffuse choroidal atrophy, patchy choroidal atrophy, Lacquer cracks, macular neovascularization, tractional maculopathy, and glaucomatous field defect involving the foveal region. Tractional myopathy may lead to retinoschisis, foveal detachment, and lamellar and full-thickness macular holes. Treatment of myopic MNV is anti-VEGF injections, and treatment of tractional maculopathy involves vitrectomy with non-foveal ILM peeling. Angioid streaks are breaks occurring in a calcified Bruch's membrane. They typically appear to either radiate from or circumscribe the optic nerve head. They tend to increase in length, width, and number over time. Mild ocular and head trauma can lead to sudden expansion of angioid streaks and occurrence of multiple subretinal hemorrhages. Systemic associations of angioid streaks include pseudoxanthoma elasticum, Paget disease of bone, Marfan syndrome, Ehlers-Danlos syndrome, and sickle cell anemia. Other than angioid streaks, ocular features of pseudoxanthoma elasticum include port orange, comet tails, pattern dystrophy-like changes, and optic nerve erosion. Vision declines in eyes with angioid streaks because of macular neovascularization or development of choroidal atrophy. Management of eyes with angioid streaks include prevention of ocular trauma with protective eyewear and anti-VEGF therapy for macular neovascularization. Breaks in Bruch's membrane may also occur following blunt ocular trauma and inflammatory chorioretinopathies. Thank you for listening.